Hello, future RNs. We're going to do a quick overview of Unit 8 personality disorders. Personality disorders are super fun to work with and super frustrating at the same time because, right, we can't necessarily fix your personality. This is who you are. It's ingrained in you. But we have 10 different personality disorders and we've divided them into 3 different clusters. So cluster A are your odd and eccentric, cluster B are dramatic, emotional, erratic, and cluster C is anxious and fearful. Risk factors, these are learned behaviors, right? If we're talking nature or nurture, personality disorders comes from the nurture or neglect, trauma, abuse. So especially, right, borderline personality disorder is one most everyone in healthcare is familiar with. There's studies, right? Medical professionals can see changes to the brain in females who had childhood sexual trauma, who then later have personality disorders. We then have to look at the diathesis stress model. Is there that genetic vulnerability? What's the temperament of the individual? You can have 2 children raised in the same environment and each one turn out differently. So our cluster A, those are our odd, are paranoid, schizoid, and schizotypal. So paranoid personality disorder is just like it sounds like. These are individuals who are paranoid. Right? And when we talked about schizophrenia, it's, schizophrenia, they're paranoid the CIA's out to get them. Someone with paranoid personality disorder might just be really worried and controlling in a relationship because they think that their significant other is cheating on them, even if there's no basis for it. They're going to be hypervigilant. They're going to be just distrustful and suspicious, and there's going to be no proof. There is no proof that their girlfriend is cheating on them, but they are going to think it. Nursing care, we got to be straightforward. We got to use simple language, right? If they're threatening, set limits. A lot of this stuff kind of relates across the board. Treatment, most of these patients are going to reject treatment. So across the board, because this is a personality disorder, because it's who you are, most of these individuals are not going to have insight into the fact that there's a problem. So they're not going to go get treatment. Second, because it's personality, meds are not going to fix this. For all of these, first-line treatment is going to be psychotherapy of some type. Group therapy can be good for certain of these certain personality disorders. Some are a little bit more challenging in group therapy. And then for meds, we're going to look at what is wrong with the patient. There is no clear-cut, hey, right, you have bipolar, we're going to give you lithium. Doesn't exist in personality disorders because we have to look at each individual patient and what's going on. So our next cluster A is schizoid. Schizoid, right, we talked about the 40-year-old virgin, socially withdrawn, right? They don't have normal emotional expressions. They're viewed as odd, and they are seen as kind of weird, eccentric, right? That 40-year-old virgin, when you put him in a social relationship, in a social situation, he had strange behaviors. He didn't know how to act. So these patients are seen as eccentric because they don't know how to have those social relationships. They have emotional detachment. They don't want a social relationship. There's no desire or joy from it. Our nursing care, we have to not be too nice because it can make them uncomfortable. We don't want to force them into socialization. We want to protect them from bullying. And again, our first line treatment is going to be psychotherapy. We could do some antipsychotics or antidepressants, but again, it's going to depend on the patient. Our last cluster A is your schizotypal. So this is kind of like a schizophrenia light. They're going to be weird. They're going to be unusual. They're not going to blend in. They're going to have magical thinking, right? Odd beliefs, inappropriate affect. We see some paranoia. And you can usually get these patients to understand where that weird thinking is coming from. These are people who are more likely to join a cult and kind of like they're going to go in and drink the Kool-Aid and they will believe what happens. They're reluctant in social situations because they're anxious. So as nurses, we need to understand they might want to be alone. This is a patient who may need more time in their room. They're not going to do well in milieu. They may struggle in group therapy. We have to watch out for their strange beliefs, right? Black magic, cults. And again, treatment of choice is going to be psychotherapy. We may do some meds if there's something else going on, but we got to watch these patients. We watched this video and then we got into cluster B. These are your erratic. These are so much more emotional, and they're your histrionic, narcissistic, antisocial, and borderline. And most of these you know. Histrionic, right? We think hysterical. We're going to think you're drama queen. We're going to think you're soap opera star. They're self-centered. They're emotional. They're attention-seeking. They're impulsive and flirtatious. And it has to be all about them. And because of that, their relationships don't last. And they don't see their role in the breaking down of the relationship. It's all everyone else's fault. We have to understand, right, that seductive behavior is a response to distress. We got to watch ourselves and keep our boundaries. I tell you all the time, don't go in patients' rooms. We need to use concrete language. We have to role model appropriate behavior. We have to assess for suicidality. And again, treatment of choice for histrionic is going to be psychotherapy. And we have to watch, right? This is the patient who's going to be yelling and screaming to call 911 because they cut their finger and got a paper cut. And they're going to be like, call an ambulance. There's so much blood. They're probably exaggerating, but we're going to go over it. We're going to assess them. And we still have, even if we know they're probably exaggerating, we still have to treat them appropriately. Narcissists. These are the ones you'll probably know the most about. They lack empathy. They're entitled. They think their poop doesn't stink. They think they're just the best. But deep down, right, we get to that Freud, that unconscious, what's going on with these patients. They have a weak self-esteem. They're hypersensitive to criticism, so they come across as arrogant. We have to remain neutral and avoid power struggling. I am sure everyone can think about a narcissist. We all know some, whether it's personally or in the news, right? We hear about these, and these people just think they are the best. Treatment of choice, it's going to be therapy. However, you have to get a narcissist to realize that there is something wrong with them. And again, in personality disorders, you lack that insight to realize there's something wrong with you, which makes it hard to treat. But therapy would be our number one. Borderline personality disorder. Oh my gosh, we see this so often. And because of this emotional ability, because of the unstable self-image, because of this impulsivity, I think I already said that, in self-harm, we see these patients more often in psychiatric facilities. So knowing that these patients are high risk for suicide, what do we have to think about? There's that marked instability. They're labile, right? We have to watch our therapeutic communication because they split. They can't see gray. Everything is black or white. They love you or they hate you. And they will tell you, like, you are the best nurse ever. I love you. Everyone else is so mean to me. But we have to know how to respond to that. We have to assess for suicidality. We have to keep safety measures. They are afraid. I think it's on the next slide. Right? They're afraid that fear of abandonment, right? With that unstable relationships. So they're afraid that people are going to leave them. So we have to look out for that. They're self-destructive. And a lot of it comes from this feeling of emptiness. We have to be matter of fact. We have to watch out for safety. They form relationships quickly. And again, just like everything else, therapy, psychotherapy is the best. DBT, dialectical behavioral therapy, it's what you see frequently. Meds are going to address, again, comorbidities, what else is going to go on. And we have to address the self-destruction. We see these patients much more often in psychiatric facilities because of the mood swings, the impulsiveness, and the self-injury. Having traits of borderline personality disorder is a risk factor for suicide. Our favorite one to discuss, antisocial personality disorders. These are your serial killers. They're deceitful. They lack remorse. It's all about self-gratification. They're impulsive. They take risks. They're into criminal misconduct, right? These are like mob hitmen, right? They want power. They want pleasure. They don't care about you. They don't care about your rights. They don't care about anyone else. And we have to be careful. We have to watch out for safety because, right, do they hurt someone else? And we need to assess, right? We talked about conduct disorder with pediatric patients. If you don't treat conduct disorder, it turns into antisocial. So nursing care, we have to set boundaries, right? We don't want to argue with these patients. This is what it is. We don't want a power struggle. They're going to manipulate and not feel guilt. And they can have anger and aggression. Mood stabilizer, SSRIs are kind of what we're going to need. Again, therapy. But it's really hard because we have to get this patient to admit that they have a problem. And we have to get them to seek out care. So cluster C, these are anxious patients and they do everything because of anxiety. So avoidant personality disorder, they avoid new relationships. They are socially isolated. They might have like one friend who has been their best friend since like middle school. They again will stay in a bad relationship versus getting into a new one because they fear rejection. They feel that they're inferior. We need to be friendly. We need to be reassuring. We don't want to push them into social situations because that's just going to make it worse. We want to give them assertiveness training. We want to do psychotherapy. We want to teach them how to advocate for themselves. Dependent personality, this one is just like it sounds like. They're submissive, they're clingy, they want other people to take care of them, right? This is an adult who has separation anxiety. We want, right, our end goals, we want them to be able to be on their own. We want them to make their own decisions, and we're going to get there through psychotherapy. We have to watch our transference and countertransference, especially if we're taking care of the patient. We don't want them to think, hey, like someone else is taking more care of me than someone else. And last but not least, obsessive compulsive personality disorder. That P, right, in OCPD, don't confuse with OCD, that P stands for perfectionist. This is someone who is stubborn. Everything has to be the right way, right? My army people, right, it has to be dress right dress. You need it perfect order. The bathroom towels have to be folded just this right way, even if no one will ever see those bathroom towels, right? Rigid standards. They're going to be focused so much on what they're doing, their work, their crafts, their hobbies, because it has to be perfect. And honestly, when we talk about their crafts and hobbies, they're going to have a whole hidden away room closet with craft supplies because they will never stick with a hobby. Because if they cannot do it perfectly, they're just not going to do it. We have to watch power struggle. We have to provide structure, and we have to look at their ritualistic behaviors. Does it take them longer to get ready because they're going to have to make sure everything is perfect? We have to look at unhealthy coping mechanisms. Hey, I get that you really like cleaning the house, but sometimes we need to do something relaxing. Therapy is going to be our best bet, just like everything else, right? We need to get them through and get them realize that the behaviors are unreasonable and get them working on kind of what they can do to work through it and with their relationships. Prozac, I don't ever really see anafranil. It exists. It helps. It can help. We don't use it too much, but Prozac is one we would use with these OCPD patients. And then we watched the video. We got some more videos if y'all want to watch them, but that's it, right? Personality disorders are super fun, but there are 10 of them. We need to be able to distinguish between them. If y'all have any questions, please reach out and let me know. Otherwise, have an awesome day.